Hi guys, so today we're gonna do paper 4. So I've just done paper 3, so please watch that as well if you haven't already. So, okay, paper 4, we start with ear examination. So for 2 points, we need to inspect the auricle, the external canal, and the eardrum, and talk about otoscopy. Right, so, okay, most of the inner ear and the middle ear are inaccessible to direct examination. So we can only inspect the external ear. So structures of the external ear include the auricle, the helix, the antihelix, the tragus, and the lobule here. So inspection of the auricle and the external ear includes just looking for any areas of swelling, any deformities, any visible lesions that we can see. And in the ear canal, if we can see any obstruction, whether that's by any foreign object or by cerumen or earwax. And then otoscopy is basically gonna enable us to look much more deeper into the ear canal. So we use an otoscope, preferably with the largest speculum possible. We insert it in the ear, and to help us straighten the ear canal for adult patients, what we can do is when we insert the otoscope, we can pull the helix or the auricle, like, what do you call it? Pull it up and back slightly like this, right? So that just straightens the ear canal a bit, better, and it would help us, visualize the ear canal better. And things that we look for are, again, any abnormal discharge, any cerumen or earwax. If we see earwax, we know its color and its consistency. Any lesions in the ear canal. Also, we can have a look at the tympanic membrane or the eardrum. Normally, it shouldn't have any perforations or, abnormal exudates or any discharge. So that's basically it. And for 3 points, we need to do the whispered voice test, Weber test, and Rinne test. So this is for hearing acuity. So to test for hearing acuity, we need to do these 3 tests. All right, so starting with the whispered voice test, what we need to do is we go behind the patient, or if you want to stay in front of the patient, just ask them to close their eyes so they can't lip read what you're saying. Okay, so for instance, the doctor goes behind me, I'm the patient, and the doctor occludes one of my ears so that I can't hear in that ear, so that he or she can just test one ear at a time. And the doctor will then whisper a combination of 3 numbers and letters. So for instance, 5AX, and ask the patient to repeat the series of numbers and letters. So in my case, it would be 5AX. And you repeat this procedure on the opposite ear. So you occlude this ear to test hearing acuity in this ear with a different combination of numbers and letters, okay? And if you detect any sensory loss via this whispered voice test, then you need to perform the Weber test and the Rinne test to help you identify which type of hearing loss is present. So if it's either conductive hearing loss or sensorineural hearing loss. The Weber test and the Rinne test are performed in conjunction with each other to help us determine the type of hearing loss present. So it can either be a conductive hearing loss, which is due to the damage in the external ear and impaired air conductance, and sensorineural hearing loss is usually due to the damage in the cochlea, so the inner ear itself, or the damage in the vestibulocochlear nerve. Okay, so that's cranial nerve 8, I believe. To perform the Weber test, which is the test for lateralization, what we need to do is get a 512 Hz tuning fork, tap it on the heel of our hand, place it on top of the patient's head, and ask the patient where does he or she hear the sound, or where does he or she hear the sound the loudest. And normally the patient should hear it equally loud on both sides. So if the patient hears it equally loud on both sides, meaning there's no lateralization, then this can have 3 outcomes. This can either be normal bilateral sensorineural hearing loss or bilateral conductive hearing loss. If you want more explanations, I've done this many times in my other videos. I think the best one to watch is the cranial nerves, actually, because I go really deep into the explanations about these types of hearing loss in why the Weber test would show this outcome if there is no lateralization and so on. Okay, so again, to repeat, when we do this and the patient hears it equally loud on both sides, that can have three outcomes: either normal, bilateral sensorineural, or bilateral conductive hearing loss. If there's lateralization, meaning that the patient hears it louder on one side, then this means that this ear can have conductive hearing loss, or the opposite ear can have sensorineural hearing loss. The Rinne test we perform to help us further investigate the type of hearing loss and if it's bilateral or unilateral. So we do is we get tuning for 512 hertz, we tap it on the heel of our hand, place it on the mastoid bone just behind the ear, and ask the patient to let us know when he or she stops the sound, stops hearing the sound. So the patient says now, and we place it next to their ear with the U shape of the tuning fork facing forwards, and ask, do you still hear the sound? If the patient says, I still hear the sound, this is positive Rinne test, meaning that the air conductance is intact and it's working, which means that air conductance is greater than bone conductance, which is the normal result, by the way. So positive Rinne test means that this can either be normal or this ear can have sensorineural hearing loss. And if you do that and place it on the mastoid bone and place it there when the patient can't hear the sound anymore, and the patient says, I can't hear the sound anymore, so this means that bone conduction equals air conduction, or bone conduction is greater than air conduction. This means that air conduction is impaired in this ear, suggesting conductive hearing loss. Yeah, so that's how we use these tests. Okay, so I know that I went over that really quickly, but please watch my cranial nerve examination video for more and better explanation for these tests. Right, so respiratory system: anterior chest examination, including inspection, palpation, ductal affirmatus, chest expansion, percussion, and auscultation. Right, so inspection of the anterior chest. Let's start with so this is for 5 points, by the way. We start with general inspection. Yeah, so we look at the patient and anteriorly, so facing them. So things that we look for is the rate and the rhythm and the type of breathing. So normal rate is 12 to 20 per minute. Okay, so we count respiration rate by just looking at the number of the rise of the chest. Okay, and if this is greater, then the patient is tachypnic, which may indicate either they're nervous or respiratory distress or something. We also assess the rhythm of breathing. Are they breathing in a regular manner, or are they breathing and then going through periods of apnea and going back to normal breathing? So we just look at the rate, the rhythm, type of breathing as well. Is it labored breathing? Do they look like they're struggling to breathe and using accessory muscles to help them breathe? Do they show signs of retraction? So this is particularly obvious when someone is having really bad asthma attacks. So you could see suprasternal retraction, intercostal retraction, which means that those spaces between the ribs and the space here, it would dip and become deeper as the patient tries to breathe. So that's retraction. You can also look for things like the color of their skin, if they're pale, or in a worst scenario, cyanotic. This indicates that their breathing is not very efficient. What else? So, okay, AP diameter as well. So if they have a barreled chest, which means that their AP diameter is greater than 0.9, then this suggests a hyperinflated lung, like in conditions such as COPD. Okay, so I think that's it for the general inspection. So more specifically for anterior chest examination, we can look at tracheal displacement. So the trachea should be in the midline, and if the trachea gets pushed to one side or becomes displaced, which means it's not in the middle anymore, this can be due to several things like growing mass in the neck, which pushes the trachea, or a large pneumothorax, okay? Also, you could look at any asymmetry in the lung and any asymmetry in the breathing, which can indicate things like pleural effusion or a large pneumothorax, any deformities in the thoracic cavity, any scars from previous surgeries, if the patient has a chest drain attached to him, any lesions, any enchymosis, bruises. What else? I think that's it for inspection. Let me know if I missed something. So for palpation, there's a few things. So firstly, we need to palpate for any areas of tenderness. And then we need to palpate for lung expansion. So we place, I'm not going to be able to do this. We basically place, okay, just imagine this is the person's anterior chest. We place our thumbs kind of like lateral to the rib cage, and we ask the patient to inhale and exhale. And during inhalation, because the lung fills with air, it should expand. So our fingers should move further away from each other. And when they exhale, the lung empties with air, which means that their lung should decrease in size, and our fingers should go back to go closer together. And the things that we're looking for in this test is the symmetry of the movement and the range of the movement. So if there's any asymmetries in the movement, then this suggests things like, again, pleural effusion or pneumothorax. If the range of the movement is very minimal, then this suggests like restrictive lung disease. And palpation also includes palpation, tactile fremitus. So palpation for tactile fremitus, right? So tactile fremitus are basically just palpable sound waves generated in the bronchopulmonary tree that gets transmitted to the chest wall as the patient speaks. So for tactile fremitus, we need to ask the patient to say 99. And in the anterior chest, there are 3 points where we need to palpate. So we use the ulnar surface of our hand and palpate for the 3 points. So 2 are like on the actual chest wall, and the last point is like on the lateral chest. So what we need to note is if there's any increase in tactile fremitus, which suggests lung consolidation. So lung consolidation means that the air-filled spaces of the lung gets filled with something else like fluids, water, or a mass that's growing inside the lung. So that would increase tactile fremitus. If there is a decrease in tactile fremitus, then this means that the transmission of the sound waves are less efficient, and this usually happens because the lung is hyperinflated. So in cases of COPD or hyperinflation of the lung, we would feel a decrease in tactile fremitus, okay? Okay, so percussion of the anterior chest. So there are 6 points to percuss in the anterior chest, and usually we do this in a step ladder fashion. You see there are like 6 different areas that I percuss in a ladder fashion. So 1, 2, 3, 4, 5, and 6 on the sides, okay? So on percussion, what we should hear usually is the resonant sound of the lung, which is normal, okay? If there's any dullness, then this again indicates consolidation. So moving on to auscultation. So again, we use those exact same 6 points for auscultation. So we use our stethoscope to listen in those 6 key areas in the anterior chest for like breath sounds, and we need to determine if they're normal breath sounds. So normal breath sounds are vesicular breath sounds, which are heard pretty much in most of the lung. Vesicular sounds are soft and low pitch, and inspiration is greater than expiration, and there's no gap in between. If there's lung consolidation, you would hear bronchial sounds in the lung parenchyma away from the main the main airways. Okay, so bronchial breath sounds are normal if you hear them really close to the actual main airways. Okay, so like the trachea, for instance. So bronchial breath sounds means that the expiration is longer than inspiration, and there's a definite gap in between. And the sound is usually higher in pitch compared to vesicular. Bronchovesicular is somewhere in between. So inspiration equals expiration, and there's a gap in between. So again, this is abnormal only if heard far away from the main airways. Okay. Also, for auscultation, you need to not just identify the type of breathing in the breath sounds, you also need to listen for any adventitious breath sounds. So adventitious breath sounds are just added sounds or superimposed sounds on the normal breath sounds. So we have wheezing, we have crackles, and we have pleural friction rub. I literally just explained these in the previous video, and please watch that for further explanation. Otherwise, I'll be sitting here for forever. So after that, so if in any case you hear any adventitious breath sounds, you need to test for transmitted voice sounds. So that includes egophony, bronchophony, and whispered pectoriloquy. Again, I've explained this in the previous video, so please watch that because my voice is just drying up, repeating myself so many times. Okay, I think that's it for auscultation. So the whole anterior chest examination is for five points. So I think we've covered pretty much all of it. For the next one, it's kidney palpation right and left. And percussion tenderness of the kidneys for 5 points. Okay, so for kidney palpation, we need the patient lying supine, and we need one hand placed below the kidney, and we push up, and with the other hand we palpate the right upper quadrant. So I'm doing it on the left side first, but you need to do this on both sides. So you need to palpate and press down with this hand as the patient exhales, actually. So ask the patient to inhale and exhale, and on exhalation you press down to feel the kidneys. So don't be upset if you don't. It's easier to feel it in like very slim people, and if there's something wrong with the kidney, if the kidney is enlarged, for instance. Again, you do this on the other side. Okay, so this is called balloting of the kidneys. I'm not really sure, but yeah, you just do that. Okay, and percussion tenderness of the kidneys. So with this, you need to ask the patient to sit on the examination bed, and you place one hand on the CVA, the costovertebral angle, and you strike it with the ulnar surface of your hand, on both sides. So the left and the right kidneys. And normally this shouldn't cause any pain, but if the patient reports pain when you do this, then this points towards something like pyelonephritis. Just a quick side note with the palpation and the percussion of the kidneys. This is my right. So the right kidney is actually 3 centimeters lower than the left kidney because of the liver. So because the liver is there, it's not really pushing. It's just because of the arrangement of the organs in the abdomen. The presence of the liver on the right upper quadrant means that the right kidney is 3 cm lower than the left one. So just keep that in consideration when you're palpating and percussing for the kidneys, okay? So the next and the last section is the peripheral vascular system. So we need to do the Allen test with interpretation for 2.5 points, and postural color changes test with interpretation. Right, so Allen test, guys. Allen test is a test for arterial insufficiency in the hands, okay? So this is also a test that we do to check for the patency of the ulnar artery before we do anything, before we puncture the radial artery for a procedure or something. So for instance, if you're doing an arterial blood gas, that's usually done in the radial artery. So before we puncture, damage, and injure the radial artery, we need to ensure that the ulnar artery is patent so that it can still perfuse the hand in case we damage the radial artery, okay? So the Allen test involves asking the patient to make a tight, really, really tight fist. And we occlude the radial and the ulnar artery with our thumbs. Obviously, I won't be able to do it. So they're making a tight fist, you occlude the radial and the ulnar artery with your thumbs. And you ask, I'm not doing it properly, guys, I'm just gonna show you and describe what you should see. And ask them to open their palm. And this should be pale when they open it, okay? Because they've just squeezed all the blood out there and you're preventing blood from coming back in. So when they open it, it should be pale. And what you do is you release the ulnar artery while still compressing the radial artery. And what you should see is the reperfusion of the hand. So the color returns between 3 to 5 seconds. So that's normal. If there's persistent pallor or paleness of the palm, then this indicates that the ulnar artery is probably obstructed or just not patent. So please do not puncture the radial in that case, okay? So that is the Allen test. The next one is postural color changes test with interpretation. So this postural color changes test is actually the Berger's test. So the Berger's test is the test for arterial insufficiency in the legs. So what we need to do is lie the patient supine. We need to elevate both of their legs to about 45 to 90. It really depends on the person's mobility, but let's just say 45 to 90 degrees, whatever, whichever range of motion they can do. Because this again depends on the patient's mobility in their hips, Not everyone's the same. So just elevate both of their legs while they're lying supine for about, let's say, 2 minutes until there's maximal pallor in the legs, until the legs actually drain with blood. And then you ask them to sit on the examination bed with their legs dangling down. And what you should see, well, in this case, now gravity is aiding the reperfusion. So what you should see is the filling of those vessels again, with the help of gravity, and the return of the pinkish color of the skin under 10 seconds. And again, persistent pallor or, refilling of the legs with blood that takes more than 10 seconds is a sign of arterial insufficiency. Also, you need to watch out for reactive rubor on dependency. So that just means the initial loss of pallor followed by the spreading redness in both legs. So this is called reactive rubor. I think that's what it's called. So you need to watch out for this because this is also a positive test for arterial insufficiency.